Hello, good afternoon, everyone. I'm Dr. Santosh Patil. I'm a senior consultant laparoscopic surgeon working in Hosmet Hospital, Bangalore, and I'm also a professor of surgery in general surgery as well as minimal access surgery. Today, I'm going to discuss about the important topic that is about constipation and its consequences, and what are the care that need to be taken to address the consequences of the constipation. So constipation is very common gastrointestinal problem. Most of the patients that land to the hospital of GI related problems have constipation as a prime complaint. And by definition, constipation is a symptom or a condition that is characterized by difficult or infrequent bowel habits. Many people experience these type of symptoms, but there is a proper definition and medical terminology what we put forward. That is, a patient who has less than three bowel movements in a week, usually we term to have a constipation. Other factors are also there, like if a patient has hard stools or passes pellet like stools in a day, again is termed to have constipation. Or patient who has to strain a lot while passing stools, or patient who has associated symptoms in the form of bleeding per rectum or bleeding or passing fresh blood or blood while passing stools that associated with hard stools, again we term it as constipation. So, who are the patients who are usually affected? It affects every individual or every ages and every race, and there is no again socioeconomic differences where the patient suffers from constipation. So basically, it affects everyone who have irregular eating habits, irregular water drinking habits, all these things which I will be discussing in detail. The topic why we have selected the constipation is it's a very common symptoms, and the consequences that is again associated with the topic are plenty if the constipation is neglected, if the constipation is left from acute to chronicity. For disease usually is acute phase which has to be addressed, and if left untreated, the chronic constipation has its own side effects. The complications that are associated with constipations are plenty, which I will be discussing in detail. That is the reason this topic has been selected. So before going to the constipation complications of the constipation, I'll be discussing some subtypes of the constipations. The subtypes of constipations are, there are three different types. One is a functional type of constipation. Then there is something called as chronic idiopathic constipation, and third variety is a secondary type of constipation. So, what is this functional constipation? Functional constipation is one where there is no organic cause, there is no organic gastrointestinal pathology that can be identified. So, it is the most prevalent form of constipation, which is seen in about 29.6% of the world population. Here, there is infrequent bowel movements without any evidence of structural or organic cause. So, what are the associated symptoms that are associated with this type of constipation is usually patients who do not take adequate water and psychological issues, or there is no proper toilet training for the kids, usually in the younger or adolescent age group, and certain medications that leads to again irregular bowel habits, and there is a strong family since few patients associated with constipation. So these are functional where there is no exact or organic cause. Then there is something called as chronic idiopathic constipation. The word idiopathic in medical terminology is one where exact cause cannot be identified, or there is no specific reason for this. Usually, this constitute about less than 5% of the constipation cases. And the third type of constipation which I discussed is about the secondary causes. Means there is an underlying pathology or the cause which can be corrected, or it can be in the form of a certain medical disorders, or there may be a dietary issues, medical disorders in the form of chronic diabetes mellitus that leads to neuropathy, that leads to gastroparesis, which is in the form of like the bowel movements over time decreases because the nerves get damaged in chronic diabetes mellitus, or there may be a structural abnormality. The structural abnormality may be in the form of the patient may be having an associated fissure in with acute fissure, where patient has hesitant to pass stools because of the pain, and patient goes into a form of constipation which again worsens the underlying condition fissure. And there may be a thrombosed hemorrhoids which again patient hesitates to pain because of the unbearable pain, or there may be anal canal malformation in the form of anal canal stenosis in pediatric age group, which leads to again a secondary type of constipation. So, if we consider these three types, these the causes of constipations are plenty. If we can summarize easily, they are dietary causes, where patient with inadequate fiber intake, which is a prime cause. Usually, people eat a lot of food that does not have fiber. Fiber helps in getting a lot of water into the gastrointestinal tract and increase the roughage, the bulk quantity of the stools, where the patient passes the stools without any discomfort. So people who have lack of fiber usually tend to have constipation, or they strain a lot while passing stools. And inadequate intake of water. We always tell patient adequacy, the water intake should be adequate enough to prevent constipation. There is a basic simple physiology in this, because whenever we eat food, maximum food gets absorbed, and the water content of the food and the water what we drink get absorbed maximum in the intestine. The intestine is the small intestine as the large intestine. As the food becomes into a fecal matter and passes to the lowermost part of the GI tract, most of the water gets absorbed. So if you tend to have habit of drinking less amount of water, the patient more absorption of water takes place in the proximal gut and the distal part, that the lower part of the intestine only you can find is a hard impacted stools. So that is the reason, if the adequate water consumption is there, the absorption is adequate and the stool formation is also adequate, so patient doesn't have to strain while passing stools. These are certain dietary factors. The other dietary factors, like in the form of over usage of the tea and coffee and alcohol, again causes constipation. And important anatomical causes, I already discussed: anal canal stenosis, atresia, fissure ano, thrombosed hemorrhoids, and certain tumors which obstruct the luminal pathway, that is the intestinal pathway, again leads to severe constipation. There are certain neurological causes also, where Hirschsprung disease, which is a disease usually associated with absence of nerve plexus. It's because we, as gastrointestinal tract, the gut motility is associated with, like, we need nerve impulses for the gut to propel forward and push the bowel contents forward. If there are absence of nerve plexus, again there will be associated constipation. Usually, these certain diseases that have been described are Hirschsprung disease, intestinal atresia, and neurological dysplasias, and certain pseudo obstructions also, where there is absence or less sympathetic stimulation, leading to constipation. There are certain drugs that have been caused for the constipation, like certain anticholinergics. These are the type of the drugs which are used for chronic COPD patients, or certain narcotics or the painkillers what we use, again tend to cause constipation. And say certain patients, like patients who are on depression, who are taking antidepressive medication, tend to have psychotropic drugs, what we call it, tend to have decrease the gut motility. So whenever there is decrease in the gut motility, yes, again these patients are tend to have repeated attacks of constipation. And certain metabolic disorders like hypokalemia. Patients with hypokalemia, potassium is a very significant electrolyte that our body needs. Whenever the potassium levels are at the lower levels, usually the gut motility decreases. Again, patient will have constipation. Certain patients who have hypothyroidism, diabetes mellitus, all these things contribute to the causes of constipation. So when you now you know the basic cause, like what is constipation by definition, and certain causes of constipation and different types of constipation. I'll be discussing what are the consequences. What happens if a patient neglects the symptoms of constipation, and he what are the sequelae, what are the consequences that are associated with constipation. For easy understanding, constipation can be acute constipation, where a patient has severe acute obstruction, means he is not able to pass stools because of immediate blockage, which is acute, where the symptoms are immediate onset, where patient needs to be addressed immediately to treat the cause. Some constipations are chronic constipation, means again a patient where 3 to 4 weeks of repeated attacks of like hard stools, repeated attacks of straining, repeated, is not able to pass stools less than three bowel movements in a week, that goes on for like this for 4 to 6 weeks, then a complications of constipation starts setting in. What are these? These are certain benign anorectal disorders, which we term as hemorrhoids, which a basic layman term is a piles, or anal fissures, and anorectal abscess and fistula formation. So yes, these are the complications that are associated with chronic constipation. I will not be discussing the complications that are associated with acute complications. Mostly this topic will be dealing with chronic constipation, because most of the strata, like maximum population usually associated with complication, land into this category. So I'll be discussing in detail, or if points about the hemorrhoids, fissures, fistulas, and perianal or anorectal abscesses, and I'll be discussing certain management aspect. This management aspect, you can say, like it can be tailored according to surgeon and the according to the patient's presentation. I'll be discussing. You can just understand what I'm trying to say. Hemorrhoids are what are basically hemorrhoids. Hemorrhoids, or what we call as piles, are nothing but vascular plexus, which are situated in the anal area, in the bottom area, which are nicely controlled or held up by the cushions or connective tissues in the anal area. Whenever patient strains or passes hard stools, he has to sit a lot on the commode, or while passing stools, or he has to strain a lot. These connective tissue gets dislodged, like what we call as loss of anal cushion happens. And once this loss of anal cushion happens, the vascular plexus usually tend to drain downwards. When they start draining or pull downwards, those are nothing but what we term as hemorrhoid. These are plexus of vasculatures. So the prevalence of hemorrhoids is around 13 to 36% overall in general population. And whenever we do a colonoscopy or a screening sigmoidoscopy, the incidence is about 38%. And of this 38%, usually 44% of the patients of hemorrhoids tend to be symptomatic. Symptomatic in the sense they produce the symptoms in the form of bleeding. So, what are the symptoms that are associated? The symptoms associated with hemorrhoids are usually a painless bleeding. Patient usually comes with a painless bleeding while passing stools, and there will be a drop of blood in the pan. This is classical presentation of hemorrhoids if the disease is very early. There is a categorization of the hemorrhoids, which I'll be discussing next, is grade 1, grade 2, and grade 3, and grade 4, where grade 1 and grade 2 are usually present as painless bleeding. There is a plexus of vessel which is constantly eroded by the hard stools, and patient present with drops of fresh bloods while passing stools, because they are situated above the dentate line. There is a term called as dentate line, where in the anal area, where below the dentate line they are usually painful conditions, and above that are usually painless conditions. So grade 1 and grade 2 usually tend to be above the dentate line, are usually painless, so present just with hard constipation on detailed history and drops of fresh bloods while passing stools. If the patient goes for grade 4, where it is the piles comes out and gets stuck very badly, what we term it as a complicated hemorrhoid, also termed as thrombosed hemorrhoids, is a painful condition. This is again one more clinical scenario, what we term as prolapsed hemorrhoids or thrombosed hemorrhoids. So presentation can vary in the spectrum of asymptomatic only constipation with bleeding, which is painless, or it can be a severe thrombosed hemorrhoids with some mass coming at the anal region. So what once a patient comes with this, what how to diagnose? The diagnosis absolutely clinically with good detailed history, and a surgeon usually examines the patient by digital rectal examination by finger, gloved finger. Patient is examined, and we do a anoscope, or what we call as proctoscope, to evaluate what is the grading of the hemorrhoids and to see any associated complications, that is associated fissures or any other reasons, that is secondary malignancies or other pathologies are associated. We'll look for a other condition by using a proctoscope. That is purely diagnosis. If a patient is more than 40 years, a screening sigmoidoscopy is a mandatory to look for any malignancies, which can be a secondary cause for hemorrhoid. So once we are diagnosed a hemorrhoid, so what are the treatment options for the patient that are available? Yes, certain initially grade 1 and grade 2 can be managed with medical management or some lifestyle modifications. As I told, it is purely because of the constipation. We need to stop patient doing what he's doing that is wrong, that is leading to constipation. Plenty of fluid, hydrate thoroughly, and increase fiber. And there are certain laxatives that can be given, or bulk forming stool, bulk forming drug medications that can be given to increase the gut motility and also prevents the constipation. Some stool softeners can also be given. There are certain medications, newer medications are also available, like calcium oxalate or medications which helps in decreasing the congestion in these blood vessels and to certain extent reduce the bleeding episodes. These are usually conservative. If the bleeding persists or the patient disease progresses from grade 1 to grade 2, grade 3, the treatment options are plenty. Previously, or the what we call as the conventional technique of operating hemorrhoids is by surgery. By we used to cut at the bottom area and we do the technique is called as Milligan Morgan technique, and then there is a Ferguson's technique where we cut the hemorrhoidal tissue and ligate the base of the blood vessel. That usually treats the base main problem, that is we remove the hemorrhoid. But the disadvantages are also associated with this, because as we cut the skin around the perianal region, it is associated with severe pain, and patient will have a lot of post-operative analgesia requirement will be there, and patient there may be associated bleeding during the surgery, which is associated again with open surgeries. Yes, and patient that's also very mild or transient, very what we call a very temporary side effect of the surgery is going to be a usually patient if you operate all three hemorrhoids in one setting, patient may have blockage leading to stenosis. These are certain side effects, or what we can say the disadvantages of these surgeries. There are now newer surgeries which are available. The best among them is being the stapler hemorrhoidectomy and also laser hemorrhoidectomy. The word itself is stapler hemorrhoidopexy. Means here the anal cushions which are lost are usually fixed with the help of a stapler. What we do, we use a stapler which is a disposable. So once we use for one patient, we do not use for another. It's a dispose or discarded. We use a stapler, and above the dentate line, we use a purse string like sutures and cut the almost 0.5 centimeter of the tissue, so the laxity of the connective tissue which is there because of the constant training is removed, and the hemorrhoids are pulled up and fixed. Basically it is stapler hemorrhoidopexy. We are fixing the hemorrhoidal tissue high up. Over time what happens, there will be uh, so- la- over time the blood vessel usually shrink in size, and usually the disease is cured. The advantages are plenty here. It is a painless procedure. You can say literally very minimal blood or bloodless surgery, and patient with advanced ages, like patient who are taking medications, patients who are on bleeding disorders, patient who are at high risk for undergoing open surgery, patients who tend to have like a lot of bleeding disorders also can undergo stapler surgery, because the bleeding chances are less and the pain is also extremely less. The results are excellent. There is other latest technique, as I told. There is laser surgery also, where a laser machine is used, and the hemorrhoidal base in the submucosal each area we burn, or with laser we burn the hemorrhoidal blood vessels, and usually it shrinks over time. There are new laser latest technique also. Hal technique is there, where hemorrhoidal artery ligation is done with the help of a Doppler. Again, facilities are there. So treatment options are plenty. Patients with early stages can be treated conservatively. As the disease progresses to second and third stage, options are again stapler hemorrhoidopexy or laser surgeries. Grade 4 thrombosed hemorrhoids, usually we go initially with the conservative treatment, followed by immediate surgery after 2 weeks if the congestion is less. So these are the different treatment options that are available for hemorrhoids. So the next complication that is associated with constipation is fissure. Very common entity, or GI problem, what we call. Because constipation, what does it do? As the hard stool tries to negotiate the sphincter or the anal area, it tears that area because of the overstretching of the sphincter. So basically, what is fissure? It is nothing but a linear tear in the anal mucosa, usually extending from the dentate line up to the anal verge. As I said, the dentate line up to there to the anal verge or external opening, the tear happens, and that tear usually leads towards severe unbearable pain. So once there is an unbearable pain, the sphincter, the anal area which is there, it has got a sphincter which goes into an involuntary spasm. So once the patient goes into involuntary spasm, patient has is reluctant to pass stools, again leading to a cycle of formation of constipation. So it is basically fissure. There are different types of fissure again: acute fissures and chronic fissures. Acute fissures are the one where the patient has severe tear mainly because of the severe constipation, one episode which leads to tear of the anal mucosa, or it can be because of multiple episodes of diarrhea, which leads to again tear of the anal mucosa. Chronic constipation, or what we term as chronic fissure, is a term that is described when a patient has fissure and persists for more than 4 to 8 weeks and not been treated. Those patients lead to chronicity. So once there is chronicity, hard stools goes forms, there is tear, then there is persistently high internal sphincter contraction leading to spasm, further leading to pain, and patient becomes so if you understand this cycle, or what we call as the chain of formation, we need to break this change for the patient to treat the fissure. So I'll be discussing in detail about the treatment aspect also. So, for basic understanding, there are different types of fissure depending upon the site. Usually, 90% of the fissures are on the posterior wall of the anal area. Almost 10 to 25% are on the anterior wall of the anal wall. If the fissures are on the lateral wall, there are high chances there may be an underlying pathology in the form of inflammatory bowel disease or a tuberculosis or HIV disease. These are the causes which produces a typical type of fissures that needs to be addressed. So, how to diagnose fissure? Fissure diagnosis is absolutely a clinical diagnosis, or what we tell as a history diagnosis. So, I encounter most of my patients like they will pass stools with pain. They have unbearable pain while passing stools, and after passing the stools episode is over, they have constant pain or burning sensation in and around the anal area for at least 3 to 4 hours post defecation. So it's a classical presentation of fissure in ano. And yes, if the tear is severe, it is associated with bleeding. The bleeding is usually fresh blood that is coated to the feces. This is a differentiating point. What we teach, hemorrhoids has a painless drop like blood, fissure painful bleeding with streaks of blood coating the feces. So again, what we do once we know this diagnosis, we confirm it by doing a digital rectal examination. A gloved finger is tried to examine to look for the sphincter tone and to assess the severity of the disease, and also try to assess how much extent is the fissure. These are usually seen in acute fissure. There are, as I said, there is chronic fissure also. In chronic fissure, usually there are indurated edges, and as there is a constant straining happening, there will be a skin tag. The skin around the anal area usually elongated, and redundant skin is formed. What we term it as a sentinel tag is associated with chronic anal fissure. Again, the treatment aspects, yes, there are medical management as well as surgical management. I usually tell, if it is an acute fissure, immediate treatment is attained, good medical management is given. 80 to 90% of the fissures can be cured. It's reverse in chronic fissures. It is only 10% of the times the medicines work in chronic fissure. 80 to 90% of the patient in chronic fissure may require surgery, because most of the time medical management, the sphincter has gone into so much fibrosis and spasm. Usually medical management will not help. So what are the medical management that are available? Yes, we have to, as I told, there is a cycle that is there. Patient has constipation, try to prevent constipation, give good stool softeners, and try make sure he passes stools without any discomfort or without any straining. High fiber diet can be given. In acute fissure, seeds bath, we ask the patient to sit in a warm bucket bath with 2 drops of potassium permanganate, or sometimes 2 drops of betadine, to prevent the inflammation or secondary infection that sets in because there is a tear. And there are certain medications also that are available in the form of lignocaine. It's a local anesthetic agent that helps in applying the ulcer wound area or the tear area, which will give some pain relief. This is only pain relief. What about the sphincter that has gone into spasm? There are certain medications that can help in reducing the sphincter spasm also, like what we use, the calcium channel blockers are there, and some latest some topical nitrates are also available. There are different combination of medicines that are available in the form of ointments that can be applied, which gives good pain relief. So some people use Botox also, botulism toxin, to release the sphincter spasm. It's a one-time technique where usually patients are pain-free and spasm-free for almost 4 to 6 weeks. It's a repeated procedure. You have to again undergo the procedure repeatedly to prevent these symptoms. So there are surgical options also available. There is something called as lateral internal sphincterotomy, which we do if the sphincter has gone into severe spasm. Sphincter relaxes to a certain extent, and patient will have pain-free period and constipation. If we treat constipation simultaneously, the tear usually heals over 4 to 6 weeks. There are certain disadvantages also associated with the sphincterotomy. Some patient may have some incontinence if the sphincter is cut for too long, but it may not be seen with every individual. Very, very rarely, if the spasm is very, very severe, neglected case of uh, anal fissure, usually we go for a sphincterotomy. So other if the sphincter, if only there is an associated fissure where the sphincter spasm is normal, usually we usually go for a only sphincterotomy without treating the fissure. We can go for local advancement flaps are also available where we remove the entire fissure, and a advancement flap can be used to cover the fissure. Plenty of options. Fissurotomy is there. Fissurectomies are there. We remove the entire fissure and we close it primarily. So plenty of options are there depending upon how what diseases you have, how bad the disease is, how bad the chronicity of the disease, what are the sequelae that are associated, sentinel tag excision. Plenty of options are available for treating the fissures. So that is about the complications. One is the hemorrhoids or what we call as piles. The second is the fissure, and third is anorectal abscess and fistula. I'm saying anorectal abscess and fistula simultaneously because anorectal abscess is left untreated or it goes into complication. It bursts. The abscess is nothing but collection of pus and in and around the anal region, and it bursts open to the skin that forms a fistula. So anorectal abscess and fistula usually we discuss simultaneously. Abscess is an acute presentation. Once it bursts open, pus drains out. Usually, patient may land into fistula. That is the reason any patient who has pain in and around the perineal region, consult your colorectal surgeon or a general surgeon immediately so that it can be addressed. If it is an abscess, a control or a drained, a properly planned incision and drainage can prevent the abscess going into the fistula formation. Okay, so I'll be discussing what are anorectal abscess. For the stools to pass smoothly from the anal region, there should be a mucus. This mucus is usually formed or produced by the crypto glandular substance, or what we call glands that are available. Almost 15 to 20 glands are available. Once these glands are secrete mucus, only then a patient can pass stools. During hard constipation, one or two gland ducts or the opening of these glands may be blocked or clogged. What happens? The glands will swell in size, and over time, this swollen, the mucus gets secondarily infected, forming an abscess. So it's an anorectal abscess. Mainly, again, you can see it is mainly because of again the constipation. So once abscess is formed, there are different types of abscess. It's an ischiorectal fossa abscess, it's a perianal abscess, or supralevator abscess. The abscess in the perianal region can be of different variety, and it can burst internally into the anal canal, or it can burst outside to the skin area, leading to a fistula formation. So, what is this fistula? What is abscess? I told abscess is nothing but a formation of a pus. Fistula is a once the abscess bursts open, it forms a thin linear tract which is lined by an epithelial tissue which does not heal until unless a surgical intervention is done. So, what happens to the patient? He produces constant fecal discharge from that opening at the skin level, or there can be a mucus discharge constantly happening at the skin level, which again lead to blockage of the skin, leading to again abscess formation, multiple fistula opening. There are plenty of complications that are associated. So I'll be just putting up some brief points about the fistula. The fistulas can be a simple fistula and a complex fistula. Many patient comes to me like they want a cure from fistula, a cure from fistula. Sometimes what happen if the fistula tract is very straightforward and a low-lying fistula, not interfering the sphincter. Means sphincter is nothing but a sphincter is a muscle-like ring that helps in controlling our continence so that we can pass stools without any problem. If the sphincter is not involved and the opening of the fistula is below that sphincter, usually the results are good. If there is a complex fistula where the fistula tracts are multiple or it is traversing through plenty of intersphincteric area, then we term it as complex fistula, where the treatment is usually tricky. There are plenty of treatment options still available, but again, as I said, the word itself is it's a complex fistula where usually the recurrences will be there, and patient needs plenty sometimes a staged procedure to treat this type of complex fistula. And as I said, 80% of these fistulas again are because of the abscess cryptograndular infection. And remember, causes are secondary causes, that is Crohn's disease, some trauma or some malignancy again will lead to fistula formation. So when do we diagnose a fistula, or what are the criteria to diagnose fistula? Simple, again, history taking is very important. In the past, there may have been episode of severe pain in and around the perineal region with an pus formation which was not drained or which burst open to the skin level, leading to fistula formation. And if there is an abscess, anorectal abscess, patient will present with a swelling or bogginess or swelling which is so big enough it becomes difficult for the patient to sit properly on a chair, and he has high grade fever, and on examination there is a collection of pus or what we call as fluctuation in and around area, and that is an indication for immediate drainage of an abscess or surgery. Simultaneously, I'll be discussing about the fistula also. The fistula, sometimes if it is a linear tract, does not require any investigation. We usually look for the internal opening by putting a dye under anesthesia or OPD also. And if the internal opening is difficult to locate, as I said, if it is a complex fistula, yes, your doctor may advise you to go for the next higher investigation in the form of MR fistulogram. That is nothing but a MRI of the bottom area or to assess the fistula. It helps in tracking the fistula tract, if it is a single tract, it is a multiple tracts, so that a surgery can be planned accordingly. And endorectal ultrasound is the one latest investigation that will again help in tracking the fistula tract, what is the extent, what are, because these are the things which helps us a surgeon to identify the tract whether the sphincter is involved. Because if I plan for a surgery, sphincter get damaged, which is unacceptable. That can be planned before surgery itself, whether sphincter is can be preserved or sphincter has to be sacrificed, to what extent it has to be, or what are the treatment options that can be done, which I'll be discussing the treatment options. The treatment options, as I said, purely surgical. There is no conservative treatment or medical management in anorectal abscess or fistula. As I said, anorectal abscess, purely immediate condition, acute condition. The pus has to be drained, immediate admission, and under anesthesia, patient has to be treated with incision and drainage. That is for the abscess, where again abscess will be there, that has to be need dressing every day. Usually the abscess everything resolves. Still a patient with well drained abscess also, chances of 30% chances of this patient going into fistula in future is a possibility. So you should accept that as well, because internal opening will be burst as the abscess tend to occur at the bulge occurs at the skin level. There may be an internal opening that is happening at the rectal level also, where the fistula tract forms. So once a fistula is formed, what are the treatment options available? A fistulotomy means if it is a low-lying fistula, no sphincters are involved, we usually put a probe and lay open the entire fistula tract and clear the epithelialized tissue so that a new granulation tissue takes place and the healing process takes. What we term it is fistulotomy for simple type of fistulas. A fibrin glue can be injected. Yes, again that is an option, but again. Internal opening identification is a very important in fibrin glue injection, and fistula plugs are there, and endoanal advancement flaps are also available. And there is a latest technique of lift where what we call is ligation of intersphincteric fistula tract is there, where we usually make an incision in and around the intersphincteric area and identify the tract and interrupt the tract. The basic concept is interrupting the external opening and internal opening is the key principle here. We interrupt the tract in between, and the internal opening usually needs to be disconnected and buzzed. So laser ablation options are also available. Yes, it fits a straightforward simple fistula, laser ablation. These are the techniques which are again for simple fistula. If the fistula is complex, a staged procedure, as I said, usually we place a set-on. If the fistula is blocked and there is pus already collected, we cannot go for primary surgery immediately. In such cases, we need to drain the abscess by putting a set-ons. And once the fistula tract heals and inflammation reduces, we go for again repeat MR fistulogram. Then again we look for the tract, healed tract, and then we plan for a staged surgery. So there are different surgical options that are available for fistula. Every surgery has its own advantages and certain disadvantages, again, which need to be discussed in detail, which may not be the scope of this presentation. I think that was the topic which I wanted to discuss with you guys. The important is, do not let the constipation. It's a very simple symptom or a disease, what we term, if not left or addressed properly on time, may lead to chronicity. Chronic complications have its own consequences. Like I discussed, it will lead unnecessary land into the fissure, fistulas, or hemorrhoids, again, which will definitely need surgical intervention or plenty of spending in the form of medications to treat this. I hope it was a discussion or a topic which helped you guys. I hope I was good enough to pass on the message what I wanted to do. Thank you. And I think the session is open for the question and answers. If you have any doubts, please put forward so that we can. I think I have a few questions here. Sciatica problem and solution. Sciatica is purely a neurological or abnormal posture related problem where the nerve gets compressed. Usually, not in this topic we'll discuss, and I'm not the expert for the sciatica problem. And we have a second question: reason and treatment for hemorrhoids. Yes, I already discussed the prime reason for hemorrhoid is chronic constipation, where patient strains a lot and the anal cushions are lost and the hemorrhoidal plexus. These are nothing but group of blood vessels which are present in the anal region, which tend to fall downwards in the form of piles or blood vessels. These are nothing but piles. And treatment I discussed again in detail. There are plenty of options. The open surgeries are there, the latest technique of stapler surgeries are there, hemorrhoidectomy, hemorrhoidopexy, and laser surgeries, yes, with good results. Even laser surgery, these are all what you can say is the daycare surgeries. Laser surgery, stapler, hemorrhoidopexy, these are basically daycare surgery. We admit a patient, we operate, by evening the patient is going home once the anesthesia effects are gone. Yes, plenty of treatment options. Okay, I have another question that says pain while passing stool sometimes. Yes, it could be an associated fissure, or we need to examine what exactly is the cause. More history will definitely give to the diagnosis. Then, as I said, the causes of pain in the perineal regions are plenty. It can be just because of a fissure, neglected, hard constipation, single attack of fissure, acute fissure can cause pain. Hemorrhoids, which is thrombosed, can cause again be a reason for the pain. Yes, and if there is an abscess, acute condition again leads to pain. Yeah. So I have one more question here. Piles curable without operating. See, yeah. Once you are diagnosed with piles, as I said, there is a grading of the piles: stage one, stage two, stage three, stage four. Whatever grade one, grade two, grade three, and grade four. Once you land into grade one or grade two, there is nothing like can be cured. Your disease can be halted with certain medication, prevent constipation. As I said, there are certain medication that can reduce the congestion in these blood vessels. Yes, there is certain medication that will prevent constipation. Disease per se is going to remain same. With medical management, can it be cured? Unlikely. It has to, at the end of the day, down the line, if the disease progresses, it has to be treated by surgically only. There is no cure for piles without absolute medication. Few people say yes, it can be. I don't know whether the piles totally disappear with any medication. No. Okay, I have one more question here. I have this problem every year during October, November. Mostly, even after taking treatment, it comes every year during this time. Why? I'm not exactly sure what exactly is the problem. You get pain, or you have piles, or you have symptoms of fissure. If you have pain during this time, this could be the reason because of the repeated constipation attacks that may be occurring during this time. Need to cross check, and I need a most probably I need a better detailed history on this problem. I'm not exactly have this problem every year. Can you be more specific? What problem? Pain or bleeding? Okay, we have one more person here. For piles, fissures, does it get cured from medicines or is cured only through surgery? See, as I said, acute fissures can be cured with medication alone. With good lifestyle modification, no repeated attacks of constipation, no repeated injury. If there is a repeated tear, overstretching anal area because of the hard constipation, repeated tear, it may not heal. In adolescents and pediatric age group, usually patients, because of the poor toilet training, have these episodes of acute fissure, which can be cured with good toilet training, good laxatives, and good stool softener, and also by good local anesthetic agents in the form of ointments. Yes, it can be cured in early stages. If it goes into chronic fissure, repeated attacks, unlikely it can be treated with medical management. It requires surgery. Same applies with the piles. Stage 1, give good medical management. Disease can be halted in that area, or stage 1 or grade 1 only. If the disease progresses to grade 3, grade 4, there is no option other than surgical treatment for the piles. I hope I'm clear in this regard. Yeah, we have one more question. When we will get to know that we should go for surgery? It is very important question. Yes, I'd like to address. If it is interfering with your day-to-day activity, there are different. If it is a piles is painless bleeding. You are losing blood constantly, repeated attacks of passing fresh blood in the stools, that is leading to anemia, weakness, and patients, it is bothering like it is gone into thrombosed, bothersome. Piles is not only in grade 1, grade 2, in the anal area, it is coming out of the anal area, associated with pain. Better get it operated, don't wait for it. Same applies for the fissure. If the repeated attacks are there, if patient, if you're not able to sit properly because of the pain, if the pain is constant and you are not able to treat the constipation properly, fissure is very bothersome, which has led to chronicity of the fissure, yes, go for surgical option. Let the doctor examine you. Always don't take decision on your own or by listening some things which may not be correct. Let your one history or one symptom may not be an indication for intervention. I must be very clear here. Your one symptom or one symptom which you think may not be an indication for surgery, there may be associated symptoms, associated findings. Let the doctor examine you and take a proper decision only after examination. Whether you, and as I said, there are plenty of treatment options also. Let the doctor take his decision when to operate, when not to operate, and what type of surgeries are required for you. Yes. One more question I have here. When the constipation is not corrected for a long time, is any surgery advised? As I said, constipation causes are plenty. If the constipation is associated with abnormality in the GI tract, in the form of abnormality in the GI tract, as I told, some surgically corrected conditions are also there. Like if the anal manometry, what we do, we need to check there is a defecation problem, there is a prolapse of the rectum that needs to be fixed surgically. As I told, in the pediatric age group, the anal opening may be very flimsy. Anal opening, what I mean, anal stenosis, anal atresia. In such cases, again, surgically, it has to be corrected. The constipation, yes, there are certain indication where a constipation has to be corrected surgically. Yes.